Good morning, students. This is Professor Crawford, and this video is on shock. So I'm just going to set my little timer right now and get started. This review session is a two-part, and this is part one of shock. To give you an overview, shock is a very comprehensive, life-threatening condition that occurs when the blood flow of the body and oxygen delivery to the tissues and cells are inadequate. Something is going on where the delivery of blood is inadequate. One of the classical signs that we see with shock is going to be the low blood pressure, hypotension. What I'm going to be doing for this presentation or this review session, I'm using Lewis to go through a little bit of a review. She covers the concept of shock really beautifully. Another handout that you may want to pull out is this handout that I prepared for you, Nursing Interventions with Medical Surgical Patients in Shock. I thought that it would be important that I created that because shock tends to be an advanced medical surgical critical care occurrence or condition. Because of the life-threatening nature of shock, those patients are often cared for in the intensive care unit. But we do have to cover it in fundamentals because it can be at any point in caring for your patient or a postoperative patient that they can go into shock. So it's going to be important that you understand the different types of shocks, how to assess for signs and symptoms, and how to implement very rapid nursing interventions. Lewis covers shock beautifully, and she includes a lot of the advanced critical care concepts like the pulmonary arterial pressure, the hemodynamic indices, as well as the wedge pressures. And I'm not going to go through that because having taught critical care at Stroger Hospital, Cook County Hospital, that's reserved for critical care. So I'm going through this quite carefully. And in the lecture that you saw yesterday during the week, you were able to follow through the medical surgical focus. So let's go ahead and get started now. Okay. As I mentioned, we often see this in the critical care unit, and this chapter is 67 that Lewis covers that you already know. So as a nurse, it's going to be important that you understand the underlying mechanisms of shock and that you recognize these very subtle signs and symptoms of shock, as well as the more obvious and apparent signs and symptoms. And then you have to go ahead and do a very quick assessment and appropriate nursing interventions. So this is just a bit of an overview. There are 4 categories of shock, or classifications as Lewis calls it. You have the cardiogenic shock, where for some reason, and usually because of an acute myocardial infarction, the heart is not able to pump effectively. The heart is pumping very weak, and it cannot push out and deliver blood into the systemic system. That is one of the problems. So if the pumping action of the heart is weak, that's what we call cardiogenic shock. If you turn to page 1778, the signs of and the pathology and the precipitating events are well described for cardiogenic shock. It talks about the pumping action, the systole, the filling mechanisms of the ventricles diastole when it's resting, maybe there's incomplete filling. But those are some of the problems that we see in cardiogenic shock. I also want you to look at page 1719, where they have a pathophysiology map of cardiogenic shock. They're talking about the stroke volume being ineffective, the cardiac output not being effective to pump and deliver the vital amount of blood through general circulation. So pretty much with cardiogenic shock, we know that there is a dysfunctioning of the pumping action of the heart. The pressure in the systemic circulation may be so high that the left ventricle just simply cannot pump against that pressure. And that can easily happen with an acute MI. There's damage to the wall of the heart, and that pumping action is going to be weak and ineffective. Now, some signs and symptoms that we'll see with a cardiogenic shock will be a tachycardia, because and tachypnea. For one thing, is that the heart is trying to beat fast enough to deliver the blood. Also, if the left ventricle cannot pump blood out, blood will be backed up into the pulmonary circulation. Therefore, the patient will be breathing faster. More blood will be backed up into the lungs, so you'll hear crackling when you do your breath sounds. And that's why I'm always on you guys about making sure you have your stethoscopes on, so that you can do those breath sounds in the patient care area. The patient will also will have cyanosis, because the oxygenated blood cannot reach the general systemic system. Also, the heart is going to be trying to pump hard, so you'll start seeing the patient with being diaphoretic. The peripheral pulses that we check in the clinical area will be weak. The skin will be cool and clammy, because the blood simply isn't reaching there. The volume will also be down. When you do capillary refill, the blood isn't there, so it'll be delayed. The renal system, blood really isn't going to general circulation, so there will be a reduction in the amount of blood flow through the renal system. Consequently, you'll see a drop in the renal blood flow and the urinary output. One of the reasons why the urinary output is also going to be decreased is because the brain, recognizes that there is a reduction in blood flow. Consequently, with that, it's going to go about and compensate, and we're going to have antidiuretic hormone, aldosterone. Those are going to be activated. Those hormones are going to be activated to withhold sodium and water. It needs to reserve and hold it back, because the body knows that there's a reduction or a loss in blood volume. So those hormones act to bring back as much blood volume as possible. Another type of shock is hypovolemic shock. Here there are two types. We have absolute, where there is a outright loss of blood and blood volume, usually from a traumatic type of injury, an external loss of blood. And then another type is relative. With relative hypovolemic shock, blood is not leaving the body. However, for some reason, the capillaries have become semi-permeable, and the blood volume in the blood vessels will be lost, because fluid will be escaping and it will be sequestered in the third space. Consequently, the blood in the cardiovascular system will be down. That will result in hypotension. Then we have what we call a distributive shock. And there are two types. We have neurogenic shock and anaphylactic shock. With the neurogenic shock, here there is a neurological injury to the spinal cord, usually at T5, thoracic 5. And that injury is going to result in hypertension because of the spinal cord injury. This is a little bit tricky. Because there is an injury to the neural system, or the neurological system, this will be the only type of shock where you'll initially see bradycardia, because you will have the parasympathetic system activated, and what we see with the other types of shock won't be activated because of that neural damage. So with neurogenic shock, you will have injury to the spinal cord at T5, and you'll see bradycardia there. Another type is the anaphylactic shock. With anaphylactic shock, this is going to be caused by some type of sensitizing agent. It could be a drug, which is why you have to find out if a patient has an allergy. It could be a chemical or a vaccine where someone has an allergic reaction. It could be to food, medication, or even insect venom. What's going to happen is that there's going to be an antibody-antigen reaction. The blood vessels become semi-permeable. There will be leakage throughout the body, including the upper airway. If that happens to the upper airway, there will be swelling in the glottal area and airway occlusion. Consequently, that is definitely a big-time emergency situation. Another type is going to be septic shock. And with septic shock, this comes about from some type of bacterial invasion or a pathogen or a microorganism that will result in this general inflammation and hypertension, lack of blood flow throughout the body, and that is what septic shock pretty much is about. And then finally, the obstructive shock is when there is some type of obstruction in the body that will prohibit the delivery of blood flow. It could be the heart with a cardiac tamponade, where there is a restrictive movement of the heart. Consequently, if the heart cannot beat or pump, you're not going to have a delivery of blood or pushing of blood through general circulation. Also, there's an instance with the abdomen where there can be an obstruction in the abdomen, a restriction, and blood will not be able to be circulated throughout the body. As I conclude part 1, I just want to highlight that I want you all to make sure that you go to Lewis because you do need to understand these types of shock. The classifications are carried out and described beautifully on page 1717. Look at those charts on page on table 17.1. Also on page 1719, take a look at the signs and symptoms like the heart rate for all 4 of those shocks. You can see how the heart rate and the blood pressure will vary. Also, you can see the clinical presentations of the major types of shock on table 67.4. The pathophysiology maps are covered for all the different types of shock. They're very clear, and they always ultimately show the decrease in tissue perfusion and the impaired cellular metabolism for all the different types of shock. So I think that she covered it beautifully. So I'm going to conclude here. This is the end of part 1 that went through the classifications and a general overview of shock. Thank you very much. Bye.